I want to introduce myself, and then our panel will introduce themselves as well, the rest of the folks on the panel. I'm Dr. Charles Cobbs. I'm the director of the Ben and Catherine Ivy Center for Advanced Brain Tumor Treatment here at Swedish Medical Center, and we are here at the Seattle Science Foundation, which is an affiliated organization, one floor up from where I work. We've had a symposium today with investigators and clinicians from around the world, around the country, who are very involved in advanced brain tumor treatment and research. And this evening, we have some of the participants in that symposium here to answer questions for patients and caregivers and family members. And I'd like to say hello to the folks that are here and present live. And I'd like to also say hello to, I think we're being live streamed on Facebook, is that right? So hello to everyone. And I think we have some people in Australia and England who are going to have some questions. And I'm appreciative of Maria Barrett for fielding some of these questions live for us. I'm a neurosurgeon and a cancer researcher, and I'm privileged to be here, and I want to maybe have, why don't we start with you, Ralph, just a quick introduction of your background and expertise, area of expertise.
Good evening. My name is Ralph Puchalski. I'm a basic research scientist working in the field of glioblastoma research. I worked at the Allen Institute for Brain Science with Dr. Greg Foltz. Maybe many of you know him. And we started and completed the IV glioblastoma atlas project, which some of you might have seen today as I described it. Now I'm working at Swedish with Dr. Cobbs on extending that to do more glioblastoma research.
Hi, I'm Jerome Graber. I'm a neuro-oncologist working in the clinic providing clinical care for our patients and clinical trials.
I'm Mary Lovely, and I am a neuro-oncology nurse. I have a PhD in symptom management and quality of life for brain tumor patients. I've been involved for over 20 years in a brain tumor support group in San Francisco, and I work with patients and families, and I also consult for different companies who want to learn more about helping patients and families.
And she's an incredibly great sailor and just came from Antarctica.
Yeah.
Well, I only came from San Francisco. My name is Dr. Michael Prados. I'm a neuro-oncologist as well. I've been at the University of California, San Francisco my whole career for the last 35 years, and my interest is in clinical trials in adults as well as children with brain tumors.
Hi, everybody. I'm Laura Rowley, and if anybody hasn't noticed, I'm a patient. And I have the Optune on my back that I wear all the time, 97%. And I'm here to talk about my feeling of being a patient here, which I love at Swedish. And as much as I love the thing that I'm suffering from, I can't complain. So thank you.
And I'd also like to highlight that Laura was in public policy and started a program to help. What exactly was the program? It went crazy, wildly well.
Okay, only 10 months ago. I was basically directing a program around the whole country with 20 different states. So in Washington State, we managed to move what we called the Basic Food Employment and Training Program from 150,000 to 40 million in 11 years. And we were the first to do it around the country, and it was all in legislation, somehow was misunderstood by a lot of people. And so I was working with other states on how to do that.
So it's good to have an advocate who knows how to get things done in the government. So I guess what we could do is just open our group to any questions that may be related to anything if someone was here during the day and saw the speakers, or any other questions that you all may have. Well, that concludes our... no, I'm sure that there's some patients and family members that might have questions about some of the clinical trials or any of the new therapies. Does anyone have any questions? Or Maria, do you have something coming in from out of the country?
Yes. Can you hear me okay on there?
Yes.
I had a question that came through today earlier when we were having our earlier presentation about why is there not as much research being done for medulloblastomas, clinical trials, research, et cetera?
I'll let Dr. Prados answer that.
So that's interesting. There actually has been a lot of research on medulloblastoma recently, so I'm not quite sure I accept
Agree with
that
that.
premise.
Yeah.
Most of the children with medulloblastoma and young adults in this country actually are enrolled in clinical trials. It's a great success story. The vast majority of children with medulloblastoma have a really good outcome in terms of survival. And there have been a huge amount of new literature about the different subsets of medulloblastoma based on genomic profiling, which has really helped us to understand the kinds of differences that are found in medulloblastoma. So we now know there's at least 4 categories of medulloblastoma, 2 of which have a very amazingly great outcome, and in fact we're trying to think about ways of decreasing the intensity of therapy for those patients. 2 groups that have a really very, very poor prognosis. And now we, instead of treating medulloblastoma as if it's one disease, we're subsetting and doing therapies that we call risk adaptive, based on their genomic profile. So there's actually been a great deal of research, and we're learning huge amounts of information because of genomic profiling and sharing of data, which is ongoing. So I think that's a success story, actually.
Thank you. There was a second part to that question that this person was asking. They said they're hearing from oncologist that they can't find any activity in the cancer, but the patient's showing severe deterioration in mobility, cognitive, psychological, and physical abilities, and no one knows what's going on. How do you address those concerns with a patient?
So I think that might be an example of why this panel actually, I think, is incredibly unique. And that today we were talking about, and sitting right here across this table, are people who work with everything from basic molecular science at single cell level through healthcare policy and healthcare implementation to provide care when it becomes available. And everything in between, clinical trials, and then sometimes what can get lost in some of these forums is actual patient care and symptom management, and that we need to kind of broaden when we talk about success. Is that of course we do want success where we see cures and where we see people living longer, and that's the endpoint of many of the trials. But there's often less attention to then living and surviving with chronic after effects of treatment and chronic side effects, and that's why we're lucky to have somebody here really representing that and bringing that attention, hopefully, to the companies too. To be focused on success at multiple levels. There's often historically been less attention and funding for symptom management, but there is better attention specifically for brain tumors, and we're seeing more attention to research into how do we improve memory outcomes, how do we address chronic after effects of radiation therapy that remains the cornerstone of treatment for most of these diseases. So I think we're also getting more interest, more research, and hopefully improving outcomes, not just in terms of tumor control and eradication, but helping improve people's quality of life and function in addition to that. So I love seeing all the different people here to kind of represent that and pay attention to those issues.
Thank you.
Let me ask Laura, do you feel like you're getting the attention that you need after having had surgery and then treatment? Do you feel like it's available for all the other lifestyle problems associated with, having to go through treatments and the NovaCure device and everything do you have ample assistance in all these other issues?
I'm not sure. The first thing that was a shock to me was being ill. And then because I was really traveling all over the country and working with different states and trying to get them going. And but the other thing is that in the evening I quickly lose my memory. And specifically when you're tired after yesterday and the last part of my chemo. So I'm just giving you a reason why this is coming up. So I'm not really sure. You guys are great and wonderful and everything, but I expected out of myself that I would immediately go back to work. And this is not because of you, but my work immediately sort of pushed me out. And I ended up spending more and more time thinking about my health, which I consider not a bad thing, and making sure I'm hitting all my appointments across the board. But the one problem I've been running into is that if I'm not working, I need to have some other focus in my life. And so that's one reason, thank you for having me here, because I really want to help in any way possible. Because my past was all about helping people, low-income people with no skills, get skills to get better paying jobs. So now thinking about how people could be healthier is very important to me. So thank you for asking.
I would like to add to that. The American Brain Tumor Association has a mentor-mentee program. And I've found that people who are mentors, and a mentor could be either a patient to a patient, caregiver to a caregiver, and you sign up to be the mentor, and people call in and say, I need help. And you can actually talk to other people and help them guide through things. And what I found is the people who are the mentor had just as much reward as the mentee, because sometimes they didn't have their job anymore, and this is something they could do, was to help other people. So if people are interested in being a mentor or need help and want to talk to somebody like themselves, or a caregiver who would like to be a mentor or need some help, that program is amazing. It's through the American Brain Tumor Association mentor-mentee program, and you just call their number and they will help you. And you might want to consider that, because it gives you something to do, because I can tell you have a lot to give.
I just wanted to add for all the people that are in here tonight, you have, except for these back two rows, there are some microphones or speakers that you can talk into. If you just press down when you have a question and raise your hand if someone calls on you, just hold that down and then you can ask that question. And otherwise, we can have you walk over here. I can bring one to you. Thanks. I have another question from online, wanting to know about complementary therapies. And Mary and Jerome, maybe you can attack that question. Food, diet, drinks, herbs. What other things can I do? Was a question from online for her husband to help him with his treatment and all the effects of his treatment that he's been going through.
Yeah, so this is a very common question. And it's kind of another level of research that can be beneficial, but is also a problem, because often we're not getting high quality research that we can give advice based on at the same as when, as a physician, we're recommending from a randomized placebo-controlled trial that was funded for X and Y reasons, we know definitively this or that. Often the quality of research we get for kind of some of the naturopathic and complementary approaches is not as good, but a lot more of them often are addressing exactly what we were just talking about. So effects on kind of symptom management, energy levels, dealing with side effects of treatment and things like nausea, GI side effects. So there is abundant research, but there is really not much education available to a lot of providers about that research. Here, we're very lucky that we have naturopathic colleagues and nutritionists available to us, but not everyone has that. And not in all areas are those people as familiar with kind of the specific and sometimes special problems that our patients deal with. So there is some information out there, but often it's not at the same quality as we get when we talk about specific medications. And again, especially when you're talking about symptom management, I would never really make any blanket statements because I don't think there's anything I've seen that convinces me that there's something that everyone should be doing. But I think it depends on the specific symptoms that a particular patient's dealing with, and you need to get a lot more kind of personalized and tailored. But it's definitely an area where we could use more quality information and research.
I think something that's frequently seen by neuro-oncologists and people like me is, a patient will say, I'm on a ketogenic diet. There's data, I heard this is great or something like that. And there's a person that did great on this diet. And there are sporadic papers and reports, but like Dr. Graber said, it's nothing that I'm aware of that's been a definitive prospective randomized, but maybe I'm missing something. But another example is, I've heard that cannabinoids are beneficial. And then, as you know, Maria, I looked into this, and I do have colleagues that are researching specific cannabinoid medications, and there was just a publication showing that maybe cannabinoids can help patients with glioblastoma. But then patients may not have a grasp of the science, and when you get into the details, there are about 15 different cannabinoids, and they each have specific molecular pathways. And so if you just go out into your local, store here in Seattle, you may have no idea what you're getting your hands on, and it may be toxic for the patient. So it's a difficult thing to wrap your head around as a care provider because it's kind of a loose-moving target without clear guidelines, as far as I know. What are your thoughts, Mike?
About cannabinoids? I think it would be great if we could have access to cannabinoids to do research. That's a big problem for us because I think there may be a story there, but we can't get access to do these things on a clinical, except very rarely now. So even to investigate or interrogate the question, we have to do clinical trials. I mean, that's sort of that's our guidepost to say it's reasonable. There's a risk-benefit ratio that favors a benefit versus a risk. Drug-drug interactions are very important for alternative and complementary medicines that can actually impact the benefit of another therapy So I think there are a lot of issues that have to be addressed. There's not a lot of funding for those kinds of things, and it's sometimes even hard for getting cannabinoids to do the kinds of studies that we need to do. But we are interested in that. We're interested in a lot of alternative medicines, but there's just a layer. There's like how many things can you do with the resources that you have that gives you good quality research that actually definitively asks and answers a question? And sometimes these are fairly low on the totem pole of research. That's not that they're not important to do. It's just there's only a certain bucket of money to do these kinds of things. And that's a shame. I personally think that's a shame.
And we're one of the states that actually has a lot of money, so this might be prime time for us, including me, to go forward with the government here. So
you may have to face the national government.
Well, we do.
Yes.
I just wanted to also add, I think the question included nutrition as well. Yes. And do you know, in my support group, one of the first things that is brought up is nutrition, because what can I do for myself? How can I control this? And so I often listen to what people tell me. I don't start telling them exactly what. And they're going for supplements and this and that. But after a while, people realize that the important thing is to have a good, strong diet because you just feel better. You have a balanced diet. And at UCSF and at the hospitals, I really strongly suggest people see their nutritionist because they sit down and talk to you about diet, and especially the oncology nutritionists know when people are taking Timodar, sometimes you don't feel good. And what are the foods that will make you get past those GI problems, and I found them to be really helpful. So, getting a consultation from a nutritionist can make a really big difference. So I know it's a big deal, and I just sit and listen to see what people are saying, but then it comes down to feeling good. What makes you feel good when you eat? And it's usually a pretty solid diet.
Yes. I don't know if you can press on that the green thing, I believe, and speak into that. Yeah.
How's that? Okay.
Perfect.
So, here at Swedish, we have a support group, okay? And we've gone through a variety of topics. We meet every other week or twice a month. And we've gone through what other people are concerned about, and if the facilitator, who's a social worker, doesn't know. And she has brought in a couple of nutritionists. So we've addressed various things like right to die, all those topics. So that resource is available, So because often you'll get common feelings. You feel like you're the only one with this kind of symptom because you don't really interact with a lot of people with glio, right? So just to make you aware, that's been very helpful for us.
Yeah, we're very lucky. We have Robin Callahan here in a support group, and she's a social worker, and I think that's a very important aspect of a brain tumor center is to have that social work support group component, because it's a forum where people can do like this and say, I've got these issues, and how does everyone else deal with it? Yes.
I'm a nurse at Swedish Cancer Institute, and we get a fair amount of glioblastomas. So my history is that we're treating them with Temodar, Avastin, and radiation in those who can have surgery. Is there anything else going on? I came tonight because I thought there might be something novel that I don't know about.
So you're at the First Hill campus of Swedish Cancer Institute? Well, for the people that don't know, this campus, or Swedish, has several campuses, and this campus is primarily the neurological campus, but there are patients that are not operated on by our group, and I guess don't see our neuro-oncologists that go over there and don't have access to trials. Is that right, or pretty much? Because we have a lot of clinical trials going on here. Why don't you speak to that?
Yeah. I think one of the first things that's been mentioned, but is that the most recent kind of advance in standard of care has been the Novo TTF device. The pivotal trial that proved the benefit of that device was done partially here at this site from the Swedish Ivy Center, and then it has been implemented, but kind of slowly, both nation and worldwide, despite the very convincing data of the benefit of wearing the device. And I think it's added a level of complexity to treatment, because when people hear about cancer and tumors, they're used to hearing about things like surgery and radiation and chemotherapy. But this is something so new, and it's really a new model and paradigm. So I think part of it also kind of maybe touches on talking about things like the support group. Even though every patient's experience and symptoms are very different, sometimes just being able to meet other people and say, oh, this is something other people have done, and kind of getting past that barrier. But I think there needs to be a lot more kind of support and education about the Novo TTF device for both care providers and patients and families, that this is a normal, quote unquote, part of this treatment now. And a lot of us are kind of catching up how to manage the side effects and symptoms, because they're not things that we're used to thinking about or managing, and we're all kind of learning together as this is implemented in standard practice.
So I think if you go on clinicaltrials.gov, there are hundreds of clinical trials for glioma patients. And one of the more difficult problems is to try and weed through that and understand how to triage. Should I go this way? Should I do that? Should I go out of the state? And that's where the value of a neuro-oncologist who's been academically trained and deals with clinical trials I mean, there's such a great resource to help filter through what this means. Eligibility, phase 1, phase 2, phase 3, this drug with this side effect, this potential risk. And I think that's the important thing. I think and it's unfortunate that patients in this country with glioblastoma, only a small percentage go on clinical trials. In children, like 80% of kids with cancer go on clinical trials. And I don't understand the reluctance or the disconnect in adults. But anyway, I think what I would really encourage, is patients who have these diseases, either they find information on clinicaltrials.gov, but even better, go see an academic neuro-oncologist who can understand and help basically interpret what these things mean and where it fits in the treatment regimen. There are lots and lots and lots of novel therapies, big studies, little studies, early phase studies, immunotherapy studies, vaccine studies, oncolytic viruses. There are so many things ongoing right now. It's a really exciting time, and it would be so much better if patients are at least potentially willing to think about enrolling in those trials, because then we could get answers a lot faster.
I'm pushing the green button. Does it work?
Oh, okay. Go ahead.
No, it's not the green button, it's the pad.
It's the pad.
Now it's
there you
working. Okay. Hi, I'm Karen Vogel. I'm a patient advocate, and I'm part of Laura's fan club. And
We got Laura has a big fan club.
Laura has a big fan club. My question is about the next generation of tumor treating field devices. Optune is in its second generation. It's still cumbersome. There are less than 1,000 people using it in the US, the last data I saw. What do you see coming down the pike in terms of lighter, more feasible devices?
The population has doubled,
Ooh.
so you know.
Yeah.
I don't know much more.
We had the Optune team here, but I think they're not here anymore,
not
so
here.
I
No,
can't
they're not
speak
here.
for what they have in their secret.
So I think kind of extending from what I was just talking about, after their benefit proven in glioblastoma, they're doing a number of clinical trials, some of which will be open here, for various other cancers. So this may become a common part of treatment added on to things that people are familiar and kind of expect, radiation, chemotherapy, and possibly the tumor treating fields may be proven beneficial for a number of other diseases, and those are active subjects of study. But going back to what we were talking about earlier, I really hope that a part of those will not just be studies about, does it work to combat the tumor, but how can we make it better? How can we understand how it works? Can we make it more effective? Can we decrease the cumbersomeness and some of the side effects and inconveniences of it? So can we improve upon it and, not just focus on, it's great, yes, we want to know that it works, we want to make it work better to control tumors, but can we make it more convenient, have less side effects and symptoms, and more manageable for people? So hopefully those will be part of those projects going forward. But some of that has to go back with the way the FDA sets up approvals for chemical treatments and medicines is very different than it is for devices. And there are kind of old historical reasons for that may or may not really be valid anymore. But hopefully we will see it become something that's more common and successful. We need more safe and effective options. And I think a lot of us believe the more we learn about cancer biology, like we talked about most of the day-to-day, is that because cancer adapts and evolves and uses multiple pathways to grow and move through the body, we clearly need things that work with multiple mechanisms of action to kind of block off the ways that cancer escapes from our different treatments. So hopefully combining different methods of treatment, molecular, radiation, surgical, tumor treating fields, things that work in different ways will kind of lead to cumulative and greater long-term successes.
Hi, my name is Stephanie Manderscheid, and I'm here on behalf of my husband, who was diagnosed with the gliosarcoma stage 4 last year. And I've been working with the End Brain Cancer Initiative with Delanne, and she recommended coming here. She's also been guiding me to find more information about genomic testing, and that's what I was hoping to find out what the advantages and disadvantages are, where we could locally access that, and is it financially feasible for patients?
So let me just make sure I get the question correctly. Your husband has a gliosarcoma, and the question is now, what are the advantages of getting genomic testing?
I do a lot of this. There are a number of commercial platforms, Foundation One, for instance, where you can actually have your physician order the test. It's CLIA approved. In other words, it's approved for commercial use. And what they'll do is a panel of kind of looking at somatic mutations or alterations in that particular tumor and actually try and match it with different kinds of therapies. For each alteration, they'll say, well, this drug might fit that alteration. Now, that's one platform. There are many, many other platforms that include not just the reading part of the DNA, but the entire genome, whole genome sequencing, which is just now coming into use. It's still investigational for use, but there are commercial companies now who are offering whole genome sequencing. The idea is that if the more you know about the biology of your individual tumor, potentially the more specific your therapy can become. So it's called precision medicine. That's the name that's used for that. And so the advantage would be, well, my glioblastoma is different than your husband's gliosarcoma, and his gliosarcoma is different than somebody else's gliosarcoma, et cetera. So why use the same treatment for all of us? We don't want, it would be futile to do that if we knew that there were substantial differences. The downside is that these, at least in glioblastoma, they have not been validated. In other words, you may find 60 alterations in a tumor, and you might match them to 10 different drugs, but we don't know that those 10 drugs, if they're used in the patient, number one, would be safe, and number two, would be effective, and we don't know how much actually gets in the brain. So there's a lot of complexity. So the downside is it's very seductive to think that because you have a mutation and there's a drug that can deal with that mutation, that it might make the tumor better in that patient, because it may not, right? So there may be a perfect match that may not work, and we still don't understand why. So the downside is that it's we're very hopeful about these things. We have to do the research for it, but it may not actually work, right? There's still a lot more that needs to be understood about DNA, right? And it's not just DNA. There's many other facets. It's the immune system that's not really being interrogated for these profiles. There's a lot of other elements in the biology. Cancer is very complicated, and glioblastoma is very, very complicated. So the good side is the more you know, the better. The more we all know, the better. The more we all evaluate things, the better. The downside is we're still not quite at a point where we can say A equals B. We're just not there yet.
And I'd like to put in my perspective too, which is, 5 years ago, when people could sequence the tumor's DNA and say you have all these mutations, there was a rush of excitement because there's one cancer in particular where there's just one key mutation called CML. The cancer is chronic myelogenous leukemia, and that one mutation can be treated with a drug and it essentially cures the cancer. Problem is, in glioblastoma, it's vastly more complicated. So when I have met with the people from Foundation One Medicine a few years ago, and we started talking about offering this to our patients, and our institution, Swedish Cancer Institute, is very heavily invested in personalized cancer genomic testing. The question that still hasn't been answered is, okay, let's say I give you X amount of dollars and you sequence my tumor DNA. In 2017, what is the percent chance that you'll find something that I can be treated with safely and that will actually improve my survival by more than a few months? And at this point, I think the bottom line is that the likelihood of something panning out from a $10,000 test is still below 5%. That would be safe, effective, and could probably do something significant in terms of treatment. And if I'm misspeaking, you guys let me know. But I mean, it's pretty much the bottom line is we don't have a CML type of cancer that we can treat, or a melanoma type cancer where there may be certain, or lung cancer where there's specific mutations often that are treatable. So.
Yeah, I would just add, so the Swedish Cancer Institute, under the leadership of Dr. Tom Brown, has a panel that offers this testing across this, and they partnership with the entire Providence system, actually, and hopefully they're going to help take us from this point where you can order these panels and get these analyses, and then we often look and say, I don't know what that means. I don't know how that guides us, whether we should do something different for you based on the analysis of your tumor. So they are doing a large research study that we're part of, then taking that data and then following each patient and trying to see, does it tell us something about how a particular patient's clinical outcome will be? Does it really predict whether they respond differently to a particular treatment or not? So hopefully we will start to get at least a hint and learn from that. And I certainly really look to our basic science colleagues who we've talked a lot with today about guiding us in further interpretation of not just going beyond what gene is altered, but how does that change cell behavior in the living organism? And does that guide us in how we should treat people more rationally and hopefully more successfully? And I listened very attentively today because I think it is going to move us forward, but we're at a point really where our reach does exceed our grasp of understanding what these tests mean, but hopefully we're moving in the right direction.
Now, there are just some basics like IDH1 and methylation. So every patient would get that anyway?
Every patient here gets those tests, and those are not treatable things. Those are predictors of, so as I mentioned in my talk earlier today, looking at biomarkers, we have some genetic and non-genetic. I guess methylation, MGMT, is not really genetic. It's a modification of the DNA. It's not a mutation. But in any event, we can look at a glioblastoma and look at the genetics of it and see if it's IDH1 mutated. And that basically, in my mind, means it's not a real glioblastoma. It's one that is in a totally different can of worms. Less than 5% of adult glioblastomas are in that category. And those are typically tumors that arise in younger people and have a totally different biology. Of the generic glioblastomas or the primary glioblastomas, they're often called, about a third of those will have MGMT promoter methylation, and that is a good thing because that means if you take Timidar, your body can't get rid of the effect of the chemo drug, so you'll have a better response. But unfortunately, about 2/3 of people with glioblastoma are unmethylated for the promoter, so their body gets rid of the effects of the chemotherapy, and it doesn't have much of an effect. So these are things that are routinely done here and at most big centers, but they're not things that are going to say, we're going to put you on this treatment or that treatment or give you a specific drug. They just kind of predict where you're going to be in terms of your response.
I just have to say something. I was born about 5 or 6 years after DNA was just described. And now we can get a whole genome sequenced for only a couple $1,000s in a couple of weeks. It's unbelievable. So I think with the data this is big data, is being accumulated and hopefully shared, because that's what the moonshot tells us we're supposed to do, is that we share all this data with everybody freely, quickly, and in real time. There's going to be a lot of information that's going to actually guide us. I really think this is one of the most important paradigm shifts that has taken place. So I think we don't know how to use the information yet, but we're going to get there because there's really smart mathematicians thinking about it, and chemists and biologists and you know, it costs less than an MRI scan, right? And we use those all the time. We can't interpret those very well either, I have to say. But I think we will interpret genome sequencing, and I think it will ultimately help your your husband. I think it will, but it's not quite yet there. And a lot of those matching drugs have been tested before in glioblastoma, but unfortunately they haven't worked because they don't get in the brain well enough at a concentration high enough, and they're not used in combination, as opposed to, you should use 3 drugs, 4 drugs versus 1 drug, as complex as the disease is. So, but we're getting there. I think we're getting there so much faster than I can imagine, but we're getting there.
I had 2 questions. So I am here on behalf of my father. He's 66 years old. He's actually being treated in Kaiser in San Francisco. So one was actually, I was curious if you knew the status of the clinical trial he is on, coming off of the MGMT. It was a trial on combining MGMT positive patients with Temodar and a drug called, I can't pronounce this, Veliparib, Veliparib. What I could look up online was it's a relatively older trial. It's not enrolling new patients right now, and it kind of, to me, felt like because he was under the Kaiser system, they were conducting the trial, and so it was convenient, and he fit the criteria to be on that trial. I was just curious if you knew what the status was there, if there's any useful information coming out. And then the second question had to do with symptom management. It seems I'm on a couple of Facebook support groups. Decadron seems to be the universal drug to combat the swelling, the edema. And a lot of the times it seems like that's almost worse than the tumor symptoms. Is there something else that doesn't cause or doesn't have all the secondary symptoms?
Yeah. You want me to talk about it? So the Veliparib study, it's now finally a phase 3. I don't think it's that old yet. It has finished accrual, so the patients are all enrolled. We don't have any outcomes data yet, but we should hopefully within the next year or 2. I think it's a good example of a rational study that builds on something we learned. When it was learned after the original temozolomide studies that temozolomide was beneficial, they did a good job, and they then kind of collected the data prospectively and planned on looking at it and got the funding to look at it, to then look at biomarkers, to pull out who are the responders and who might not be. And that's where we learned about the MGMT methylation story, and then kind of went back to the lab. So it was kind of this circuit between clinical trials, clinical care, back to the lab, back to the drawing board, learning from mistakes and benefits. So I think it's a good extension of that to then learn that this class of drugs called PARP inhibitors potentially might help to sensitize certain kinds of tumors to treatment. So there have been a number of trials with different medications and drugs in that class looking at this across a variety of cancers to see if we can build on our successes and make the available treatments we have a little more effective. So I think we're all kind of paying attention to the outcome of that study with any one of those class of agents.
Your other question about edema, this is a struggle. I mean, steroids, Decadron, is a brutal drug, but it's pretty effective. The only other alternative right now is bevacizumab, Avastin, which we do use for acute swelling or radiation-associated edema. There was a trial that, I don't know if you ever participated with human corticotropin releasing factor, which also worked pretty well, but that hasn't translated into something that people use. But it's a dilemma because you're using a drug that is harmful for the rest of the body, right? And maybe even for the tumor, but it does reduce swelling at least, and it should be used very judiciously, and that's why, again, you have to have a really good oncologist, neuro-oncologist who is comfortable with the drug, knows when to get it down as quickly as possible, and if it's on for a long time, you got to be careful about, getting off of it. I mean, there's a lot of issues related to it, but I wish we had a better drug, but we don't.
I've seen around the country, because I've always done a lot of national things, that more people are using Avastin when they just see that the swelling is out of control and the patient's so tired of using Decadron. That's one thing. And the other thing is, I know family members just have to keep on top of those symptoms of Decadron and know that, it can also cause problems with your bones. It can cause your skin to thin. It's not just the horrible feeling that you can't sleep at night. So I found that if they have they do need to know about Decadron and to look it up and to be on top of the symptoms, because sometimes people have to be on it. You can't get off that 2 milligrams or 1 milligram. So as hard as it is, just kind of hang with those symptoms and try to work with each one of them, and that at least helps.
And I hope that's something that we're doing with our patients and families, because I think one of the hard things is people see these changes in themselves and in their loved ones, and sometimes there's this temptation to blame it all on the brain tumor. And then to just kind of accept symptoms and problems and side effects, some of which are treatable or manageable, and then often with non-specialists sometimes there's a tendency to be afraid to change the dexamethasone and to lower it, but it really should be an ongoing process. And I mean, it sounds much more simple than a lot of the other stuff we talked about today, but personalizing the dose of dexamethasone. There are patients who need none and should be on none, but there are other people who need it despite the side effects, and then that leads to more medications to manage the side effects of that medication. But I think it's actually a huge part of symptom management and control, and balancing things and really personalizing patient care. But I mean, part of that is also, I think, educating family members. This is why, or if the patient themselves, this is why you're feeling not like your usual self. This is why somebody's maybe behaving a little different than usual. It adds to the chronic stress. If you cannot sleep at night, everyone feels miserable. So there's often this temptation to blame the tumor or to blame the radiation and chemotherapy for some things that might actually be fixable, and make day-to-day life more manageable, or at least understand why people are feeling the way they're feeling.
Maria, I think you have some questions from around the world.
Online. Yes, we have people listening in from Oklahoma City, Reno, Nevada, West Virginia, New York, Atlanta, Australia, and England, as well as other places. So I'm going to try to combine some of the questions that are on similar topics. Laura, we have a question for you from several people that want to know about the Optune device and how is it impacting your quality of life, and then from our experts, any other information that you'd like to provide about how you're using it, how you see it working with your patients.
So I could say that the Optune is working for me. I've gotten used to wearing it, and the 2.5 to, depending on what I've got on my back, to 7.5 pounds, and hopping around. I also walk a lot and hike a lot, so I think that really helps the way I feel. So in general, I walk at least 5 miles a day, or go up into the mountains and do that, and so that's been very, very helpful. And it took me maybe a month or two to sort of feel that way. It took that long, I would say. I did have to get massage on my back because it was constantly hurting at first. Even if you're adding 3 extra pounds, you certainly feel that. So arranging that with your doctor, like I did, was really, really helpful. And continuing that and thinking about that and what's going to make a difference. Acupuncture has also been really helpful to me. I haven't necessarily talked with my doctors about this, but will be doing in the near future. But I can say, just, some people, I think, accept this pretty quickly. And, you're just like, this is a part of my life now, so I'm just going to go with it. So is there anything that I missed? Anybody know of? My friends? My kids?
I mean, I think for me, and share if you disagree, that my role, I mean, the word doctor comes from the word docere, which means to teach. So to me, I see myself as a teacher. to help explain to patients what I know based on the medical literature, which is its own crazy language and often doesn't have to be, and then help people choose how they feel about the information we know about these different treatment options, and then kind of support patients through their decision, not to just tell them you need to do X, Y, and Z because that's what works. Because that's not really true. So hopefully I'm sharing honest information with people and also what we don't know, which doctors are often not that great at saying, but sharing things that we don't know about some of these other things like nutritional things, using complementary medicine. And any good teacher will tell you that they learn far more from their students than they ever teach. So hopefully I'm listening, and I really do feel that I learn from my patients, and then I can share that with the next patient I have, and hopefully it helps me be a better healthcare provider and advocate for my patients too, by listening to them and learning from them how they feel and what their experiences are.
I've got another one from CJ in Atlanta. He wants to know, is there any difference in treatment or trials regarding gliosarcoma versus glioblastoma? My mom was diagnosed in November of 2015 with gliosarcoma, is currently on Avastin and CCNU.
No, they're basically treated the same. Gliosarcoma is kind of a histologic variation of glioblastoma, and almost every trial that I've ever done includes gliosarcoma with glioblastoma. And most of the data, when you subset out these patients, which is a small group of glioblastoma patients who have gliosarcoma, their outcomes are really basically about the same. So we think about it as the same.
Thank you. Anybody else? I've got more. If there's other people that don't have a question, I'll ask another one. A lot of people are asking about the cannabis oils, and does that help to slow tumor growth and prevent new cells from growing? Is it showing promise in your results for dealing with brain tumors? You brought up the topic.
I don't know. I mean,
as
in
soon as you brought up the topic, we had like 10 questions come in on it.
In California, a large number of patients are using cannabis, and in various combinations with the cannabinoids.
Right.
And the dosing is just all over the board. I have no idea what they're really taking, because there's no quality assurance, at least in California at this point, about what those products really represent and what the dose concentrations of that is. With the passage of the proposition this year to make it legal in California for recreational use, all of a sudden now there's going to be a regulatory path and some accountability and some standardization for all those things. Some patients take so much, their fatigue level is terrible. And it really hurts them, but they're believers. Others will say that absolutely this is helping me, and it may be helping them feel better, sleep better, have better symptom management, but I can't tell whether it's helping their tumor, right? Because we're not doing trials, so it's an anecdote. Each patient is an anecdote. Mm-hmm. So I don't know how to answer the question because we're not doing the trials.
And like I said before, when I looked into the science behind it one time, there are cannabinoid subsets like CBD1, CBD2, all these different ones that are different molecules, and we don't really have any idea what is in a little vial of oil when you go and get it at the local store here in Seattle or wherever. But there are companies. There's a company, Stella Therapeutics here, and there's a paper that was just published showing that there's some benefit from a specific cannabinoid, and I think there is a part of science. There is some scientific evidence that these things can promote tumor killing, probably in the context of chemo and radiation. So it's complicated, but it's kind of like saying, chemo helps with cancer, so people are going out to the chemo store and getting whatever is in the chemo bag, and there's all kinds of different chemos. So if you don't get the right one, it may have bad side effects and not help you.
There is one place where we know that it has a really effective role, and that's in children with refractory seizures. These are kids who have 100 seizures per day. And cannabis with some degree of I'll just say it's uncertain what the actual best ratio would be, can actually help those kids. When they're on 5 different anticonvulsants, and they actually then respond to some forms of cannabis. So there, I think there's a definitive, I mean, a seizure is either happening or not happening, so you can tell.
I mean, I think, too, there are good studies going back quite some while, too, that for managing symptoms, there are good studies that, at least some cannabis derivatives can be beneficial for nausea. Clearly, there are wonderful studies of acupuncture for nausea. So we do have some good studies. We definitely need more, though. And I think it does. It highlights this gap we have, that there are these nice papers and research you can find about things that worked in a lab dish. I think one of the most frustrating things about this disease is, and Dr. Cobbs can talk to this, is that these tumor cells are actually really hard to grow in the lab. And they're really easy to kill. So things that work in the lab, I mean, I could go through the wall into his lab and I could squeeze a cheeseburger out over a dish of tumor cells, and they'll all die. But does that mean that cheeseburgers kill brain tumors? So there's a big gap between what works with tumor cells that are grown in a lab and then what will work in the clinical setting. And that's where we kind of need good research, but that kind of research needs an extensive amount of funding and support. So I think that's where it's difficult to really translate these basic science findings into clinical medicine.
So this was a question that came up last year, exactly the same thing. What about cannabis and cannabinoids? And I can tell you that you can ask and answer the question in a year. Mm-hmm. If you had a good phase 3 clinical trial, you could get enough patients in a year to answer the question. Mm-hmm. And it's a shame. I mean, it's a shame that it's not being done.
Dr. Cobbs, we've got a lot of people that have joined us later in this discussion. Can you just really quickly, just for them, introduce each of the panel members really quick? They've asked to find out who everybody is that's up here. So if you could just really quickly go down the line and introduce everybody that's there real quickly, just to review.
Yes, sure. This is Laura Rowley. She's a patient who's now using the Optune device, been my patient for a while. And she's also been very influential and working in the government to try to promote certain things in the I guess advocating for people with funding. Yeah, so she would like to be more involved with our advocacy. And this is Dr. Michael Prados, who was my mentor at UCSF in the early 90s. He's a neuro-oncologist at UCSF and a very knowledgeable neuro-oncologist involved in science and clinical trials. I'm the director of the Ben and Catherine Ivey Center for Advanced Brain Tumor Treatment here at Swedish Medical Center. I'm a neurosurgeon and do brain cancer research. This is Mary Lovely, who I also knew back in the 90s at UCSF, and she's been helping brain cancer patients as a patient advocate and works alongside the American Brain Tumor Association and many other organizations. This is Dr. Jerome Graber, who is a neuro-oncologist here at Swedish, who trained at Sloan Kettering in New York and joined us about a year ago or so, and does a lot of good work in clinical trials with our patients. And Ralph Puchalski at the end is a researcher who is a PhD and had worked at the Allen Brain Institute here on a big project that Greg Foltz, my predecessor, initiated to study the molecular expression of genes in tumors at the very microscopic level, which has led to a huge database, hopefully to be published in a major journal within the next few weeks, months. But online and available for free throughout the world.
Thank you.
We have it. I'd like to echo one thing Dr. Prados just said, is that my specific interest goes back about 15 years with the possible role of a viral infection, and we tried to advocate to get a pharmaceutical company to offer an antiviral drug so we could do a clinical trial. We wanted to enroll about 170 patients to get the drug from the company. Would have been in the order of a couple $1 million of drug that we would need. And unfortunately, for 15 years, despite some evidence this drug might be beneficial, we have been unable to get the company to provide the drug. And to do these studies, to do them right, you need about $3 to $5 million. So for 15 years, this question has remained unresolved. And like you said, there's a lot of things that could be perhaps sorted out and figured out. And there are so many patients that are not enrolled in clinical trials. But if you could snap your fingers and wave your wand and have them all enrolled in clinical trials and fund 10 clinical trials, you'd have a lot of these questions sorted out within a year or two.
Dr. Prados, I have a question regarding studies for DIPG, and I know you spoke about this earlier, so just for the benefit of those online, we will be posting on our braincancer.org website and Facebook pages and all of our different social media channels, as well as Seattle Science Foundation, the video broadcast from our educational portion of the event today. So Dr. Prados did quite an extensive talk about DIPG and pediatric tumors. So if you wouldn't mind speaking to that and the most recent studies and what you're working on in the area of DIPG.
So for people who don't know, DIPG is a very, very highly lethal and malignant tumor in children that arises in the pons, which is the brainstem. And these children are between the ages of 5 and 10 generally, and unfortunately their survival is very, very short. It's much worse than adult glioblastoma. And thankfully, a rare number of patients per year. In the United States, only about 300 or 400 patients per year, so it's a rare disease. Most of the work is based on, new work is based on obtaining tumor tissue from these patients, so biopsying the brainstem, which now can be done safely. And this gives us information, genomic information, that we can help to try and match up with drugs. So one aspect of what we're doing is precision medicine, which is genomically based, to try and find targets and combinations of therapies for that. That's never been done before, but now we've done our first feasibility and we're doing another trial. Another thing that's been defined just recently is a very specific mutation that's only found in this disease, basically one other disease that's rare, but only in this disease. And this mutation seems to be the key mutation driving the growth of this tumor. And now there are drugs being designed for that mutation, but we also have developed a vaccine that targets that mutation and just started that trial. We've just enrolled the first 6 patients for that study. So that's very exciting. Again, harnessing the immune system to attack the tumor cells that show this mutation. We're very excited about that. And then the other thing that we're pursuing is giving drugs directly into the brain stem. I think I mentioned earlier, it's hard to get drugs into the brain. Most drugs are created to stay out of the brain. But even chemotherapy drugs can't get into the brain. And in the brainstem, it's a very tightly wound space, and it's very hard for drugs to get there. So we're just starting and got approval to put catheters in the brainstem of children. And we're starting with 2 catheters, and we're infusing a nanoparticle that has a drug in it, a chemotherapy drug in it. And we're planning to do that every 4 to 6 weeks in these children after their radiation therapy. And then finally, we have another immunotherapy trial with a checkpoint inhibitor. So we're casting a broad net of different approaches for these kids because they have such a terrible outcome, and nothing has worked at all except radiation, which unfortunately fails after about 6 months, and children die on average in 9 months. So it's a brutal disease. But now we have some biologic information, and we have tissue from these kids, and we're studying the disease like it's never been studied before, and at least we're hopeful that we're on the right track for rationally designed clinical trials.
Hi, my name is Gadgo Hegi, and I have a comment or question. Both Dr. Cobbs and Dr. Dr. Prados. You both mentioned that not enough people are signing up for clinical trials, and you want more people to sign up. I kind of feel like me looking through clinical trials, and usually when we go to doctors, the first things they mention are always standard therapy, surgery, radiation, Tamidor, and then CCNU and other chemotherapies. And I feel like only after that I never been to a doctor that goes, here, go this clinical trial. They always have you do standard therapy first. And maybe the people that don't sign up is because maybe they're tired of all the treatment and they don't want to, especially when the treatment doesn't guarantee anything besides just more tests. So just, I guess, giving feedback there.
I'll give you my perspective. So I've worked at a community hospital. I've worked at a big university hospital. I've worked at a place like Swedish, which is kind of a community hospital, but also academic. And I'll tell you that the vast majority of neurosurgeons who are the people you first interact with, often when you have a brain tumor, are out there in the community at community hospitals where research is not part of the game plan. It's get the patient taken care of, which is great, and but also a lot of these neurosurgeons who are the first people you will encounter don't focus on brain tumors. Often they're general neurosurgeons doing spine and this and that, and they'll have a brain tumor patient pop up every now and then, and they'll do the surgery. The patient will go to an oncologist. The oncologist may not be a neuro-oncologist, and they'll get put on the standard treatment, which is appropriate. If I could fix everything and make it right, I would make sure that everybody that shows up in an ER with a possible malignant brain tumor gets sent to a center there that has clinical trials for upfront newly diagnosed tumors. But that's just not reality. And so I think what happens is people will get the standard treatment, and after a while, if that's not successful, then practically speaking, sometimes they'll say, hey, we don't have anything else to offer. Maybe go to the university or somewhere where they can, try something else. That's kind of a very frank, viewpoint, but I think that's also the reality of healthcare in America right now.
And I think patients are not the problem. And I think sometimes people say that, but in my experience, it's seldom that the patients don't want to be in the trial. I think the more common problem for me has been that patients either, there is an urgency to start treatment, obviously, but I think one of the other big obstacles is, for good reasons, people are trying to design more intelligent trials, but that often means looking at these small subsets of people with a diagnosis. And then a lot of times there are patients who want to be in a trial, who are willing to be in a trial, which is really an incredible thing. To say when you're faced with something this scary, I'm okay with being given a drug and we don't know what it will do and we don't know if it works. I'm continually inspired by the people who hear that and understand it, and they say yes. And we would not be where we are if there were not really the thousands and thousands of patients and families who agreed to be treated by a chance, by literally a flip of a coin. But I think one of the challenges now is I have patients who are agreeable and who really should be good candidates, but we don't have inclusive trials that really patients can get into who are willing to be in the studies. So I think that's a challenge for us as researchers, to make sure that we really have an adequate kind of offering of trials that any patient can be in, because then we end up with studies of this tiny subset of patients, and then we don't know if we can really apply that to people. The trials should be for patients, not the other way around, but often that's the thinking. But that means we need funding that's willing to support trials for patient populations that might not be perfect or ideal. But otherwise, we'll just end up with results that we don't know if they apply to most people, and that's not that useful.
Can I make another comment just to reinforce my bias that brain tumor patients should hopefully go to centers? I have a friend here in Seattle, and they called me last summer when I was on vacation and said her brother was somewhere in Oregon diagnosed with something that they think is a glioblastoma, but the surgeon said there's nothing to do other than biopsy because it's right near the speech area and the motor cortex on the dominant hemisphere. And I said, well, that's one perspective. Can I, why don't you have him come see me? And I operated on him, and we did the surgery awake, and he was talking to me throughout the surgery and having him move his arm and leg, and we got it all out, and then he enrolled in a clinical trial. And I'm not trying to toot my own horn or anything about the institution, but I'm just saying that there is a big difference sometimes in, I think, what can be done at a place that has a focus on these tumors, because I think this individual, if he'd had a biopsy with this gigantic tumor, wouldn't be around right now. And fortunately, he's around. He's been on a clinical trial, and I believe it's helping him. So, just education of the community to know that if someone is diagnosed, to go to a place that has these things up front, it can make a difference, I believe.
I totally agree. And I think when I was at the American Brain Tumor Association, we worked really hard to help people understand the importance of going to a center where they have doctors, neurosurgeons who commonly operate on brain tumor patients, not just spine and other types. But I have to kind of be an advocate on the other side. It's really hard to travel a long way away from home. It's hard to be away from your family when you're sick. And so one of the problems, too, is we don't have enough people and enough centers that can handle this. And the other thing I've learned recently is to do a clinical trial requires a lot of people. So if in your own center, it requires a clinical research coordinator. It requires all these people, and local doctors it's all they can do to go from patient to patient. So for them to put a clinical trial in their setting is really hard. So I am advocating also to go to the regional center if you can for a brain tumor. It's really hard because they just can't do it all. And I'm hoping at some point we will move in the direction where we have brain tumor centers. And that's where the doctors will say, that's where you should go.
So I'm going to be on the other side of this because when I first started, there were very few centers of excellence. But now, almost, you be quiet. But in the last 20 years, there have been so many well-trained academic neuro-oncologists that I don't think there's a patient who's can't find somebody within 400 or 500 miles. And to me, it's their right to know what their choices are. Even if they choose not to enroll in a trial and they choose not to go to someplace 500 miles from now, if they don't even know what the options are, I don't think that's right. And I think if, to get, and there are enough support groups that can help get a patient to a referral center too, right? If they're having difficulty. So I really, if a kid can come to me from Asia, why can't a patient get from, Kalamazoo to whatever in less than a day? I think
one of the questions is it the general oncologist to say maybe you should go to a neuro-oncologist?
Yeah, but patients have to become their own advocates to some degree as well, right? I mean, the internet is actually a very powerful tool, Facebook, all these things, and if I had a diagnosis of a pretty terrible disease, the first thing I'm going to do is go to the internet, right? Mm-hmm. And you're going to learn way more than you probably should know in the start, but at least you're going to learn that there are options. Mm-hmm. But if nobody's telling you what those options are, I think that's a shame. But anyway, it's getting better, but still, I think only about 10% or less of patients diagnosed in this country are in clinical trials for one reason or another. Anyway, you heard what I said.
You have a patient question over here.
Sure.
I just want to piggyback on that. Having gone through this recently in the last year with my husband, when you're recently diagnosed and they tell you you're going to have surgery in 3 days, it's a very emotional and stressful time, and you don't have the time to educate yourself. And excuse me. speaking and being an advocate, it's almost like, you have a social worker there, but you really need someone there to present you with, these are your other options, like you said, Dr. Prados, because I had no idea that I had other options, or that we had other options. And working with EBCI, they've really helped me to become educated and be an advocate and look for other sources. The other thing about clinical trials is, he went into surgery and had his resection, but now he doesn't qualify for much because he's not in the stage where he has a recurrence, fortunately. But so I feel like you're limited also after you have gone through those stages.
And, getting back to this patient I was mentioning, because they're a good example, when I told the family to tell the patient that it would be good for him to come see me for a second opinion, the surgeon that they had seen said, "You've got a big tumor, you got to have surgery right now." And I said, "Look, I don't want to rock." So there's a lot of weird emotional things and, territorial things going on. But I said, "Look, I don't want to rock the boat. Do what your family feels comfortable about. But from what you've told me, this is not an emergency, and he has a few days to think about things." But I think, for better or worse, a lot of times patients will show up and the neurosurgeon may say, "Look, you've got to have this out right now, period." And no discussion. And, if it was me and I had no medical background, I would do what the surgeon said. But, in reality, that it's not full disclosure. It's not saying that, there may be centers around there where you could have other alternative. But, it's a complicated social issue as well.
I will say every website, just like we were talking about, the Musella website, and Brain Cancer website, ABTA website, Brain Tumor Network website, ABC Squared, they all say, go to a regional center, go see a neuro-oncologist, go see a brain tumor doctor, neurosurgeon. So it is out there, and I do think people go see this. And so I've read it, I've written it, and that's so. There are good resources. So I hope somebody's listening in someone's family.
On that note, I'll introduce myself real quickly. I'm Maria Barrett, and I work with Dr. Cobbs and run the braincancer.org website, which Greg Foltz created prior to his passing in 2013. And we run several Facebook other channels, Pinterest, Instagram, all of them, and we put out that same information. I come from a patient perspective. My father was diagnosed in 2011 with a GBM, and Greg was his surgeon, and we came from Oregon, and I immediately hit the ground running, looking up information, and my mom was bent that they wanted to stay home. They wanted to stay in Eugene, Oregon, do the surgery at home where he could be comfortable. And I said, "How many surgeries has this guy done?" "Well, he's had 2 GBM. I said, "Well, we're not going there. We're going to be going to Seattle because Greg Foltz has a lot more in his hat than that." So it is really, really important. And that's what we do as well as patient advocacy. And we put out Brain Tumor 101 videos that Dr. Cobbs and the IB Center folks work on putting out patient education information. On that note, there's a lot of questions all surrounded around the clinical trials and the drug combinations. We heard Dr. Hood today talk about, there's not going to be one drug that cures cancer. It's going to be a modality of several things, like Dr. Graber said, combined. Having come from that portion of being a patient's daughter, helping him through as his caregiver, if any of you were a patient today, I'm going to ask this from the people online, and this was your loved one, your wife, your husband, your mother, father, going through this, looking at combinations of drugs and clinical trials, I'd like to hear from you what you would be going for. What types of combinations would you be looking for? And I know you'd all be going to large brain tumor centers, so that would be the first plug, but would love to hear your feedback, and that's from a lot of online questions we're getting as well.
Well, that's an easy one for me to start with
because you'd go where you are.
Because we have a clinical trial where the patient I was just describing is our first patient. We have a clinical trial based on an idea that Greg Foltz had of taking patients' own tumor cells, growing the stem cells of the tumor, and then doing high throughput drug screening against FDA-approved drugs of all kinds that are known to be able to go into the brain, and just getting a rank order of which drugs kill their tumor cells the best. And some of the drugs that have popped up have been totally unexpected, things that, that are used for different diseases like depression or whatever. But we have a IRB approved protocol to get the top 3 drugs that can be given in combination safely that are potent against that patient's their own tumor cells. And this gentleman is our first patient that I was talking about earlier. So the hope is that by doing a personalized approach with combinations of drugs, we can hit multiple pathways at the same time. And the reason I wanted to do combination drug treatment is because my earliest research was in the HIV research a long time ago before med school. And in that field, even though it's not exactly analogous, there's a drug for HIV, Truvada, that's got 3 antiviral drugs. If you give one antiviral drug, the virus will mutate around it about 20% of the time pretty rapidly. If you give 2 drugs, it may be 1 or 2% of the time. But if you give 3 drugs, that pretty much shuts down the ability of the virus to mutate around all 3 drugs. It's not exactly a good analogy, but we're hoping that in doing these combination treatments on a personalized way, we can knock out critical fundamental tumor pathways. And then we're going to be working with the Institute for Systems Biology to try to understand from the genetics of the tumor why that particular tumor is susceptible to those drugs. And hopefully over time with big data analysis, we can sort of get to the core of what's driving some of these. Long-winded answer, sorry.
That's okay.
Next.
Oh, come on, Dr. Graver. You want to answer this question.
Actually, I don't.
I knew
But it's a question I get a lot, and it always kind of reminds me when I get it, it isn't about what I would do, because these are important decisions in people's lives. I mean, it's really about who the person is and how they're feeling. When I look at, or people say, what would you do, or what would you want your family member to do? And if I think about my family, we're very different people, like most families, and literally every person in my family would do something wildly different. So I think it's part of the importance of having a relationship and getting to know who my patient is. And then often kind of learning not just them, but their family and support group, and kind of figuring out who they are as a person, teaching them and educating them, and then finding out what's right for them. Because clinical trials are not for everybody. There are people who don't want to be in them, and for them that's the right choice. There are people who decide not to do radiation. There are people who decide not to do things that we consider standard. So I think it's a lot more complicated question than that. But it gets to me to the heart and the importance of why I do what I do. If this was just a rubber stamp and I was telling every single patient the exact same thing all day long every day, I wouldn't be doing it. And hopefully, as we get more options, I'll have more things to offer people and help them make better choices for themselves.
Thank you.
Yeah, for somebody so young, you're quite wise. That's what I was going to say. So I think that the things right now that I'm more optimistic about, and if I was a patient, I don't know if I would make the same choice, but I'm more optimistic about are genomically based approaches, very similar to what you're talking about, as well as immunotherapy-based approaches in a cocktail that would be, and of course I'm biased because I would say I'd want to do it in a clinical trial. But if my disease was diagnosed when I'm 82 and I was paralyzed and can't walk and can't communicate, I don't know if I'd want treatment. So it is true, right? It's very patient-specific, person-specific. And I have cancer. I have a different kind of cancer. And I'm struggling with what to do with that cancer as well. And I'm an oncologist. It seems like it'd be really straightforward. I should just do this, this, and this. But there are a lot of choices. So I've got to make a choice based on what I want. My wife has cancer, right? We're working through that too. It's overwhelming, right? It is totally overwhelming when you're faced with it yourself or your wife or your kid. it's overwhelming, and even somebody who's got a lot of information will struggle, right, to make the choice, because it impacts not just you, it impacts everything, right? Your family, your neighbors, your colleagues, people all around you. So you want to make the right choice for the right reason, and it depends on what's happening in your life at the time.
Thank you. The question back here. Do you want? You got one? That's okay. No problem. Here you go. My name is Mary Ann Brodwick, and I'm a facilitator for the Whatcom County Brain Tumor Support Group that we started back in 2011 after my husband passed away in 2010. And he too had Dr. Foltz, awesome surgeon. One of the things that I see happening in our group is we have, Whatcom County may not seem that big. We get a lot of snow up there lately, but we have had quite a few people start coming through our doors, and it's the caregivers that I can talk to. I don't talk to the patients directly. But I've always felt like there's this lack of information given to the families. I'd like to know if that's changed, because I sure didn't get enough information when we were first diagnosed, which was up in Bellingham first, and then we came to Seattle, and I felt like we had more support from Dr. Foltz. But still, I was never, as a primary caregiver, taken aside and said, this is what you can expect from the Decadron and from surgery, from radiation. We sort of found it out as we lived it out. And I feel like that is such a lack in the system of care and the healthcare. So I'm just expressing it on behalf of our group, because I know that they all feel the same way. So how do you guys address the rest of the family, and how do you tell them how to live with this disease? Because it's not just the patient, it's everybody around them.
You have a really, really good point. It's different for each place. I have to say that UCSF right now is probably has the best model in the world, because I do a lot of international work, and that is they have a caregiver program. And what that is they actually have a nurse coordinator and a social worker who aligns with each person, each family who has a glioblastoma from the time they walk in the door. And they provide information over time. And sometimes that's what it needs. Not everything at once, but this is your information. And then they call on a regular basis to make sure that you're doing okay. Because we all know things change. Sometimes they change every 2 weeks. And I know many people around the country who are nurse practitioners and who are navigators. And more people are getting navigators now too. And these nurse navigators are usually the resource people for their patients and families. But there is nothing, it's not consistent anywhere. So a friend at Northwestern will have a lot of information. But then you could be 2 hospitals away and they don't have any information. One of your best ways to do it is go online, and as a support group leader, provide that information online. This is where you can go to find out about Decadron. This is where you can find about dexamethasone, about that kind of thing. But it's not consistent. It isn't consistent at all. UCLA has social workers and another caregiver support group. People recognize it more. We realize it's really important to have patient-centered care now. Not just, we're going to treat you and that's it. Patient-centered care is patient and family all working together. What's happening? How are we living with this disease? It's so much more.
She is a national treasure.
It's so much more important now to deal with everything. So I'm really excited about this navigator concept, because having a caregiver coordinator is really unique. But if you have nurse navigators, that's what they do. They start with you and they start giving you resources. And there's also sometimes patient navigators, and there's the social work navigators. So those are some options. And I'm happy to talk to anybody about it afterwards.
The model at UCSF, I think, is really an incredibly important model, and it offers research options too within the caregiver program. It's funded by an endowment. So somebody actually said, we want to create it, because you can't get reimbursed, right, for taking care of a caregiver. But we had a fundraiser and a donor, and there are more donors now, and that caregiver program has been operationalized so that the caregivers are actually part of the medical record, which is, I think, very unique. So even in the medical record of the patient, you can link to a caregiver in the electronic medical record and communicate that way too, even at a distance. So it is a great model, and I think the UCSF program is very happy to share their experience. They're actually giving talks, presentations at some of the national meetings, and it's a great model, I think. And I think it makes a huge difference in quality of life.
It makes a complete difference because we know this is a family disease. This just doesn't affect the patient. It affects the whole family. Yeah.
And I'd like to make a comment because I'm sitting between two of the top people in the world that are the upside of your question. But if I could give you, frankly speaking, again, if you took 100 neurosurgeons who, as I said, are the people that interact up front with most of these patients, I would say maybe 5 of those 100 really focus on brain tumor patients for whom that is their avocation, and then they're what they're really interested in. And so the other 95 probably spend most of their time doing, back pain and neck pain and cervical disc and lumbar disc. And then throughout their weekly routine, every now and then they may have a patient that has a brain tumor or a glioblastoma, and then they may biopsy or whatever. And some of them do phenomenal jobs and do great work. But to a lot of these people, just to know what the psychology is, it's kind of like, I'll let someone else deal with that because I want to get things that I can fix and move on and be happy. And it's tough. It takes a lot of psychological energy. And I think that the reality is that when you have a patient and you're not at a center and there's not the whole network, the whole support, it's easier just to kind of like say, okay, all right, see you guys later. I don't really want to, I know a lot of surgeons that don't tell the patient the diagnosis. I don't even want to talk about the diagnosis. That's I'll wait till the oncologist gets there because it's psychologically difficult. So I think there's a real psychological issue that may make it difficult for some people to tell you all about what's going to happen. The decadron is going to cause this problem. The Timidar is going to cause this problem, So I think that may be one of the reasons why it's not up to speed at some places, but UCSF is the exact opposite. It's just exemplary of how good it can be, but it's a major center, and a donor funded this type of program, which is just awesome. And we have a wonderful person here, Robin Callahan, who was funded by the Ivy Foundation to provide social work for all the patients. So I hope that kind of helps explain maybe why certain things are different at certain institutions.
I wanted to add to that. It's about doing your research. I had a brother that was diagnosed a year ago with an esthesioneuroblastoma, skull-based tumor, and right away we just hit the ground running, researching it, made a big file about it, and we went to 4 different centers. And some people can do that, some people it's more difficult for, but we really went around and discussed and called and had phone conferences with myself and my brother, who was not as experienced on it, and asked questions. And how would you approach this? And it was very vastly different how each doctor would approach it. And it's really important to get that knowledge before you kind of sign on the dotted line and know how they're going to approach it, because they all have a different approach. The doctor in Eugene was going to do a biopsy and then close my dad back up for his GBM and then decide what to do. I took him here to Seattle. He had 1 surgery, and that was it. He didn't have to go in twice for 2 craniotomies. It's just very important to get your information, and don't be afraid to call, and don't be afraid to try to connect and get in and go spend the time. It's worth the time to go in and meet with these doctors and have them review your MRIs and ask your list of questions. It's time very well spent. Do you have other questions? I've got a question from online. Janet has some questions about arsenic, lead, and cadmium being found in our drinking water. According to the NIH study, these metals cause brain cancer. Do you suggest that people with brain cancer test their drinking water for metals and radiation?
Okay, that's news to me.
Yeah. Someone up there know about that?
I've extensively studied things associated with brain tumors in terms of environmental toxins, all kind of stuff. The only things that we really know cause brain tumors, aside from very rare genetic links, are ionizing radiation. All kinds of toxins and environmental pollutants have been investigated, benzenes, all kind of things like that, and some of these are in certain studies associated with increased risk, like in firemen or certain rubber workers and these kind of things, but follow-up studies sometimes show that that doesn't pan out. So that would be news to me, unless someone else knows something I don't know, that lead or cadmium or what was the other one?
Arsenic.
Arsenic would be related to gliomas.
I mean, I think it touches on kind of a topic that we've been talking about a little bit before, that we may make assumptions about certain things, but human biology is more complex, you know. So in New York, brain tumor risk did come up in people who were exposed to the September 11th environment, and there's a lot of questions about things like that. There's also, you know, levels of these different, especially soft metals like mercury that I used to do research on, that are considered generally safe. We don't know about individual susceptibility. So we talked a lot today about CMV, and I think, you know, you can extrapolate a little bit. I mean, 80% plus of people have CMV and never have any ill health effects from it, but we don't understand, are unusual people susceptible to a particular thing at a level or a dose or at an agent that other people are not affected by. So, you know, in general, I can say the answer is no, but for an individual particular patient, for the vast majority of my patients, one of the first things I tell them is, I don't know why this happened to you. We don't know. But it doesn't mean I can be dismissive. I can say at a population level that hasn't been shown to be, but for you in particular, I don't know, because most of these things are complex biology, and it's probably not any one cause. It was a number of different factors, many of which we don't even understand.
I would say if anybody anywhere thinks that they have an exposure of lead or arsenic or cadmium in their drinking water, they should have it tested. And if people eat a lot of fish, they should get tested for mercury, because there are mercury levels go way up in some fish. So those are things, but I don't know if any of those things are related to gliomas.
Any other questions out here? Go ahead. Do you have a speaker there?
Yeah, I have. Hi, I'm a patient. I had glioblastoma in my brain, in my motor center. Oh, okay. I had surgery, I had radiation, I had chemo. I'm doing the TTF fields now, and I'm not planning to have a recurrent glioblastoma, but since the topic of the talk is innovative approaches to brain tumor, I was just curious about what is your current research topics in case I need to go back to treatment in the future.
So you said, since you have a glioblastoma and the topic is innovative approaches, so what are the new innovative approaches?
Yeah, I'm curious about your research in general. So in case I get some new tumor in like 2 or 3 years, so what can I expect? What kind of clinical trials are there?
Why don't I let the two neuro-oncologists discuss our clinical trials for recurrent glioblastoma?
Yeah, so I mean, there's a number of studies going on. We have several now about vaccine therapies and immunotherapies. We're starting to see trials now about combining different agents, so combining antiogenic agents that combat tumor blood vessels together with immunotherapies to hopefully have a synergistic effect and work better, and maybe also minimize some of the side effects of the immunotherapies and control swelling. I think the hard thing is I don't know what's coming, but hopefully we learn one step of the way, and maybe we have some results, and then you don't need to go in a trial, and we know something better for people. So it changes all the time, literally from day to day, what's available. But we have a number of immunotherapy trials going on now. We will be opening more, and hopefully we'll have more to offer, and ones that more people can get into.
Yeah, I mean, there's a whole spectrum, I think, and some of the more novel ones that you're asking about for using viruses to kill tumors. I mean, viruses may cause tumors, but you can also use viruses to kill tumors. And then right now, the big wave of research is on immunotherapy, which is a precision approach, right? Using your own immune system one way or another. But I do think that these trials are coming fast, and discovery is happening even faster. So, yeah, 2 years from now, I'm not sure what the next big lead's going to be, but probably in the next year or two, it'll be focused on immunotherapy and combination approaches, and maybe oncolytic viruses that are going to come up.
Hi, I'm Molly. My husband's got glio. I think one of the frustrating things is that there's nothing to do after you do the conventional treatment and while you're waiting for a recurrence. Do you know what I mean? So he's 3 years out, but it's basically seizure medication and wait. My second question is he had what they thought was a recurrence, and when they went in, there wasn't a recurrence. It was around the margin of where the tumor was resected, and it was basically glial cells, and dead ones, and radiation effect. And so obviously people have recurrences that look like recurrences, right? But for the subtle changes, how do you know without going in that this is, how the enhancement on the MRI scan, how do you know that that's a recurrence versus just a little enhancement that can come from the treatment itself?
$6 million.
Yeah, this is a very common and really frustrating problem. I think we made some progress, and one advantage for me as a clinician of being here is also working with our wonderful radiology colleagues, and that you can do advanced imaging, things like PET scans, and I find MR perfusion incredibly helpful. They're not 100%, which is still concerning and frustrating, but they can hopefully at least give us a strong hint what we're dealing with. But I think that's another area of active research where we need to make a little more progress. We've made some, but we should make more. And there's also been a little more progress pairing molecular subtypes with imaging features, so that rather than lump people together and interpret their MRIs, we might need to interpret them a little differently. I think it's one of the challenges of some of the experimental treatments in clinical trials, because they change the imaging too in ways that we're not always sure how to interpret. So especially with immunotherapy, it's a big question. We know some of these agents can cause inflammation and make the MRI look worse. How can we avoid unnecessary surgeries? If we do have to do surgery, can we at least learn something from it so we don't have to keep doing that down the road? But I think it is another area where being at a specialized center where there is advanced imaging features and really high quality interpretation can help with this really common problem.
Yeah, and I'll just add to what he said. So there are 3 techniques we use, but we don't use them all the time. But Dr. Graber kind of alluded, PET scans is how much glucose is being metabolized. So if you have an enhanced area of it on the MRI, but there's no glucose uptake, that's likely not active tumor, but it's not always the case. Another one is called MR spectroscopy, where you can actually look at the molecules that are in those cells using MRI, and if there's a high choline peak, for instance, and other things, it can indicate that that's active glioma, but that's also difficult to interpret. And then another one we do here a lot is, like he said, perfusion. You're actually looking at the amount of blood flowing through that tissue. And for necrosis, there's usually not much blood, if anything, going through it. But in an active tumor, that may have 6 times the amount of blood flow than the normal brain. But still, we often will biopsy just to know for sure.
And I just want to say that's wonderful that your husband's lived 3 years with glioblastoma. It's fantastic. But I also know that there's also an uncertainty with that, because you live from MRI to MRI. Mm-hmm. You think, and so sometimes you have to relearn to live your life. What are you going to do between those, if it's every 4 months or every 6 months now? How are you going to live and know that, oh, maybe something will happen, something won't, and just try to live normally and just have a life. So I realized that that's a big part of having someone who's had a brain tumor for a really long time.
We've kind of struggled with maintenance, the idea of maintenance, right? And it's always about risk-benefit because you don't know anything's changing if whatever you're doing for the maintenance therapy to prevent something from happening is actually working. I think immunotherapy is actually one way to get maintenance therapy. If you can prime your own immune system to recognize a tumor cell, and it's primed and it's enhanced and it's encouraged to understand if there's a new one coming, that's ongoing maintenance, if you want to think about it ultimately. So I think with these new immunotherapy approaches and trials, we may get to maintenance therapy by teaching the immune system to recognize and do something if something actually showed up. So it's always lurking and looking and seeing. So I think that is one of the promises for maintenance therapy to prevent progression.
I have a question from online. Any experience with epithelioid glioblastoma? That was a mouthful.
Aesthesio?
Epithelioid glioblastoma, they're calling it.
Oh, he's shaking his head. Right. You want? Go ahead. No, you're much younger and wiser than I am.
Uh-oh.
So, I think, again, we talked a lot today about different molecular subtypes, some of which our pathologists now are really good. We have a wonderful pathologist here, Dr. Steve Rosted, who's incredibly helpful about maybe then pairing some of these unusual subtypes. People talked about gliosarcoma, there's epithelioid glioblastoma, there's these large cell variants, there's these immune cell rich subtypes. So pairing these molecular subtypes, some of which end up on a path report, and some of which we're starting to learn match up with different molecular signatures too. So I think we're kind of just getting to that point where we know that there are different subtypes, and not quite to a point where we definitely know whether to treat them differently or not. So I think that's a really active area of research.
Would that type of tumor be included in most clinical trials?
Yeah, it would. And as far as I don't know of any specific trial for epithelioid type, subtype glioblastoma. So, but and we may, it may be buried in the other clinical trials, whether there's a subgroup. But I think everybody's getting profiled now, genomically profiled, and whatever name you put on a tumor is probably less important than its genomic characterization.
Right.
So, I think you had this young woman here. You had a question, right? Yeah.
Should be a green button, I think.
Yeah, I see it. I was wondering, so if you already had the surgery, does that change the survival rate? If you were gonna have it again, if it came back, how that would change the survival rate of the patient and that kind of stuff. I was just wondering if it would make it worse.
If the tumor got removed and then came back, got removed with surgery and then had to get another surgery, how much would the first surgery, the prior surgery, affect the survival rate of the patient during a second surgery?
Are you talking about for glioblastoma?
Yeah. It's kind of circumstantial, but.
Yeah, so that's a good question. Pretty much when we look at the survival for these tumors, historically we've said, from the diagnosis till, as long as someone lives, that's the survival. And we know that from early studies, the more that, a good resection is beneficial. But just in the last 5 or 10 years, there's been more interest in more aggressive surgery. And I've just recently reviewed a paper talking about improve survival in patients who have a complete resection, and then their tumor may come back, and if they are suitable, they have another complete resection, and they get an added benefit. Now, I'm not going to try to state that surgery, a second surgery, is going to set you back to time zero at the very beginning. It's not like that. In general, things progress, and another surgery may be beneficial. But I think we're learning it's a little bit more beneficial than we used to think, because usually in the old days, we hardly ever did a second surgery for glioblastoma, because once you had surgery, radiation, and possibly chemo, that was all that people would do. I don't know if that adequately answered your question, but it certainly is not the case that if you have a surgery and then another surgery, that it's basically like you're starting at the beginning again. Does that make sense?
Yeah, no, I think it's true. I think what's more important is not necessarily the second surgery, but how much is left behind at the second surgery. And that's complicated, and it's based on where the tumor is and how large it is, and what are the risks in doing that per se. We know we have a lot more information of what the impact of the first surgery is, much less information about the impact of the second surgery, but I would say what's more important is how much it's the therapy that comes after that second surgery, and how much tumor there is and how complicated that tumor is. It's probably more important than just the surgery itself.
I think one other factor may be functional status as well.
Absolutely.
How well the person is doing. If somebody's really sick and they're having a second surgery, as opposed to someone who's really well and really feeling pretty good and not having many symptoms, then that's a good indication that things are going to go maybe a little longer too.
I have one patient that is on the younger end of the spectrum who had refused all treatments, standard treatments, chemo, radiation, and so we were left with no other way of dealing with a tumor coming back other than operating, and she had extremely good functional status, and so we've operated several times, which is highly unusual, and people would say that's even not ethical or possibly, but there was no other option, but it's been helping her, but finally I think she's going to get treatment. But surgery does have a role, but certainly it is not the end all, and the most important factor really is, like Mary said, the functional, how people are doing.
Go ahead.
To kind of go along with the surgery question, is there any research or looking into, because right now the first thing usually people do is get surgery for a partial or total resection of a tumor. Is there any research going into, or maybe that's not the right thing to do first? Like maybe in the future we think back like, wow, I can't believe we're cutting people's heads open. Like maybe that wasn't the right move. So is there any research going into that where maybe that shouldn't be the first step?
I think that based on a huge amount of patients huge number of patients being treated, we know that for glioblastoma, if we're talking about that, if you just do a biopsy, that the prognosis is much worse in general than if you do a complete resection. So despite the fact that it's an invasive procedure and all these things, I think that if you can get as much out as possible, that's beneficial. There's never been a really good, what we call a class 1 evidence prospective randomized study, but there's been a really pretty good class 2 study, which is a study that was looking at a drug or something you can give during surgery so that tumor cells will glow under UV light, called 5-ALA. And when these tumors were resected with this technique, it allowed a really aggressive resection of the tumor, perfectly clean post-operative MRI, no evidence of tumor. And then they went back and looked at the survival of those patients who had really more resection than even a normal resection based on the MRI. And those patients did significantly better. I mean, we're not talking about massively better, but they definitely did better. So I think that the short answer is that if possible, if safe, it's best to get as much out as possible.
I have a question from Chris online. It says, being on Avastin for a little over a year, it's still working at keeping cancer at bay. Do you recommend looking for a clinical trial now, even with it currently working, or wait to look for a clinical trial until I'm told Avastin's no longer working?
I mean, I don't know that you'd get on a clinical trial while you've been on Avastin for a year with stable disease. So it may, unless you know of one, I'm not aware of one. So if what's working is working and it's not making you sick, it's really kind of hard to suggest doing something different, and not knowing if whatever that different thing is making a difference. But yeah, but yeah, I think they should keep investigating the options if and when that tumor starts to grow, right? Yeah.
And I think it highlights another point is, we use Avastin, some patients benefit tremendously from it, but there was a phase 3 randomized trial that said it wasn't beneficial. But there are clearly people who do extremely well on it, occasionally for very long periods of time. So I hope at some point, we'll do more studies looking at, the subsets of patients for whom certain things work and figure out, and they are looking in that trial at some tissue biomarkers to say, are there people who really benefit from bevacizumab and should be on it, and others who won't, and can we just rationally apply it and efficiently? It'd be nice if we had trials looking at people who are doing well, because that's, in a way, what we should be studying more, is the people who are doing great and learning why are they doing so well, and how can we carry that over to our other patients.
Can you do that trial? Dr. Cobbs?
Can you fund that trial?
Yeah, exactly. That is a question we get a lot through our braincancer.org information, people asking all the time. We're on Avastin. I thought Avastin wasn't supposed to work. We read about this trial. So that's very common. My own father was on Avastin for 2 rounds, and then we were done. We didn't see any improvement. He actually got quite worse, and so we stopped, and he improved a bit for a while. So it's like you said, it's all over the map, and there's people who I know who've been on it for quite a long time and had done very well for quite a long time. So I wanted to express the importance of brain tumor boards at centers, large centers, because you have all these different doctors looking at your information, looking at your MRIs, looking at your results, and all of those doctors, the radiation oncologist, the neurosurgeon, the neuro-oncologist, all these different aspects looking at your information. And that's why it's so important to go to a large center like UCSF and the Ivy Center, Swedish, and the larger centers, Sloan Kettering, et cetera, to get that brain tumor board of experts to get more eyes on your cases. So I can't emphasize that enough, how important that is for patients.
I will put, it's always a risk-benefit ratio, and I think there are some risks associated with Avastin over the long term. I've had patients die of Avastin treatment, strokes, other things happen, hemorrhages. So it's not innocuous. It has to be very carefully monitored, and you have to carefully think about it. The longest I've treated a patient with Avastin has been 4 years. A patient who was just so frightened of stopping, and we just kept trying to say no, lengthening the treatment, but could have done just as well without it. I have no idea whether 4 years of Avastin made any difference in that woman's life.
And I believe in England or Europe, it's not approved for glioblastoma because there's no prospective randomized clinical trials showing survival benefits. So,
Another question on the polio vaccine trial. Mary, you and I talked about this a little bit earlier today. There was a lot in the press about the polio vaccine trial, and Dr. Cobbs, you and I actually did a blog about this as well. A lot of people got real excited about what they saw because it was broadcast on the major networks, et cetera. Can you give us kind of what your perspective is on that? Any of you that want to speak to that, on the success of it, and would you recommend that to someone? That was a question we had online.
All I know is pretty much what I saw in 60 Minutes, which was very exciting, but like any clinical trial, I haven't seen the curves yet, and so the number of patients, so it's hard for me to know, but maybe my colleagues know a little bit more.
I know something about it that I will say it's a clinical trial, and the strategy of using an oncolytic virus, it's actually not a vaccine, but an oncolytic virus, is very plausible. We're using measles virus, people are using other kinds of viruses to deal with these tumors. I think for a very select group of patients with a very small tumor volume that can accommodate this treatment, which does cause some edema and swelling and other things. It's not innocuous. You know, with many early trials, sometimes you see pretty dramatic results, but then you start adding more patients and it becomes a little bit less. Anyway, I think it's a clinical trial. It's an early phase clinical trial. The phase 2 is just getting ready to start. So that's when we'll really get more information.
I think you bring up a good point that if you ever have any problem, get in it on the very earliest trial, because that's when the people always do well.
The other thing I've learned is that, okay, you're just saying you're just starting the phase 2. That means they have to recruit all the patients, they have to follow all the patients, and then they have to analyze all the data. So you're not going to find out what happened to those people for about 3 years. Mm-hmm. So we don't know. We just don't know.
We are actually out of time here tonight, but I want to encourage everyone that's listening or anybody that's here to visit Seattle Science Foundation's YouTube channel, their Facebook page, their website. All the videos from all of the educational portion from today, as well as tonight's panel, will all be posted on there, as well as our braincancer.org website and Facebook page, so you can link in and watch all of the videos, including this portion tonight. And we want to especially thank all of our experts who are here today, Dr. Cobbs and Mary Lovely, Dr. Graber, everyone. Thank you very much for being here tonight.
Thank you, Maria. Thank you, Jason, SSF staff. And I want to thank Laura and my colleagues, especially Dr. Prados from coming from out of town, and Mary Lovely from coming from out of town. And thank you all, patients and caregivers, for showing up, and the Facebook people out there.
Yeah.
Thanks again.
Thank you.